Welcome to Eye Contact. I'm Henahan. Today we're talking to Burkhard Dick about postoperative errors with refractive IOLs and what to do about them. Welcome, Burkhard. Thank you for joining us.
Thank you.
Well, when you have multifocal IOLs, you're going to have some post-op complications. When you have toric IOLs, you're going to have some complications. When you put them together, doesn't that compound the chance of complications, and what are you finding happens?
Well, it's of course a more complex situation. You're absolutely right. What is important that you take care not only of the refractive outcomes in terms of deviation from target refraction from the spherical point of view, but also from the toric version. That means that you need to know where to place exactly the torus, and that you have to deal maybe with postoperative deviations from the target refraction. But the multifocal lenses, especially the toric ones, are more suspect and more prone to deviation, of course.
Well, let's talk about the toric part. Is that a matter of centration and the procedure itself? And are you using femtosecond laser for your capsulotomy?
Well, I use both depending on the lens and the patient, or if you can afford the femtosecond laser too. But of course, as a guarantee with the femtosecond laser of 360-degree overlap of the capsule on the IOL, on the optic, I would definitely prefer the use of a femtosecond laser. The toric lens, then, of course, what is important is that you really look for the cause of the deviation. That may be a decentration, but more often it's a rotation of the IOL. And there are nice calculators, for example, astigmatismfix.com or other calculators on the market where you can easily look for the amount of deviation, and also what is the effect of the suggested rotation by the software, how much you can reduce. And based on this and the amount of deviation, of course, you make the decision if you're going to rotate, for example, re-rotate. Mm-hmm. This definitely has not to be conducted within the first 4 weeks because you want the capsular back shrinkage.
Mm-hmm. Mm-hmm. And what about the multifocal aspect? What sort of complications are you having to deal with?
Well, the most complaints are maybe a decrease of visual quality. Mm-hmm. First of all, I have to say most of the patients are very happy, but no rose comes without thorns. It's a compromise, of course, and the patients have to and willing to understand. If the motivation is high, they will to some extent accept it, but if it's more or less unacceptable because of glare, hail, or flare or something like that, you look first for dry eye, for example, issues, and treat them. I would say most importantly are the conservative approaches. For example, you look at, the most important is to look at the slit lamp before dilation, so to see if the lens is centered or not. You will nicely see it, especially with diffractive lenses. If the lens is in the line of sight, you can exactly judge if the pupil is not dilated. So, and then after seeing that, and the lens the pupil is the problem here, that the pupil may be too wide, then there is the potential use of, for example, brimonidine, 0.2%. It's off-label, but it works very nicely. After 30 minutes, there is an effect. Maximum effect is after 6 hours, for example, and it decreases tremendously the amount of halos and increases contrast sensitivity. And that is a really great tool to see if the pupil is an effect here, because it blocks the relative mydriasis, the brimonidine, or you use diluted pilocarpine, for example, or the other direction, that you see the pupil is too small and use, for example, iridoplasty, and that you can simulate this through sacroplegic or mydriatic drops, for example. And all these conservative aspects are so good, and so that means that more than 80%, including aggressive weighting, using neuroadaptation, which is totally underestimated in our community, because it takes some months, and most of the patients are not willing to accept this, especially if they are not prepared preoperatively, and you didn't speak to them and didn't address this, which is also important. These measures already contribute to 80% that lead to success, that the patients are satisfied. Most importantly, I think, is that you do not start with YAG capsulotomy, because that, if the IOL exchange is down the road, that makes it definitely more complex and more risky in terms of complications.
So it sounds like you have to spend some chair time with the patients to help them understand what
Yes.
they might encounter.
Yes.
Maybe more than with a regular lens.
Definitely, yes, yeah, of course. It's an integral part, so to say. But the patients are very clever and intelligent, and they know exactly what they want. And the more you communicate and prepare them that, for example, postoperative potential touch-up, irrespective if it's with laser or with pixel or whatever it is, or rotation, is integral part, then they don't see the postoperative, maybe intraocular procedure or surgical procedure as a failure of the entire procedure. If you prepare them, they accept it.
So you explain they may have to have some sort of touch-up, maybe a
Right,
corneal
right.
procedure or one
Yes,
thing or another.
yes.
What would you recommend to a surgeon who hasn't done a lot of multifocals or torics, who are considering doing more but they're afraid of all these complications? What do they need to know to become more skilled and be able to do these procedures?
Well, most of the colleagues I wouldn't put under pressure, because as now with the demographic evolution, that the baby boomers now come into the age of cataract surgery, more and more people will ask for premium lens technologies, for more options, especially also the patients after refractive surgery, for example, keratorefractive surgery. They are willing to pay, they are motivated to get a better solution. So definitely everybody has to think about it and to set up his own setting. And that is especially true for diagnostics. That means that you take into account in also the posterior cornea, for example, that you have a barometer or some device that tells you exactly, and you can measure the deviation, so you know exactly what is the reason for the error in order to take care of it. And then I would say you can definitely end up with happy patients down the road.
Well, I imagine some surgeons would be not too happy to think about having to do explantations or lens
absolutely.
exchange.
That is down the road the last thing I would offer, except if the deviation from the target refraction is more than 1.5 diopters or something like that. I would go for an IOL exchange early, of course. But think about the technologies that are on the market and that come up, like the light adjustable lens technology, for example. And we personally here in Bochum have already more than 10 years of experience with this. And you can nail the patients to the point they want. If there is a deviation of 3 diopters, and myopia, or astigmatism, you nail them to the point there they want it to be, and they can live with it and say they want more intermediate, more near, or something like that, in mini monovision or monovision, whatever you call it. And you nail them to 1/4 of a diopter in precision. And they are so happy, and we have 10 years experience now with great experience, and we just presented the results. And I think that is the first step, the right step into the right direction of stratified, more individual care of the patients, rather than just putting in a refractive lens or a monofocal lens, because the patient can live with it. Of course, this is not the ultimate solution down the road, although it has FDA approval, etc. But then the next technologies are showing up, and there are 4 startup companies on the market, refractive index shaping with femtosecond laser. And that makes it totally surplus that we have high biometry devices, that we have high-tech preoperative calculations, that we have high-tech preoperative counseling, intraoperative aberrometry. They all will wipe away from the market because it's all fixed down the road afterwards.
So some of the complications, the post-op complications you see with these lenses will become a thing of the past because the lenses will become a thing of the past.
Right.
Interesting. Well, we'll look forward to that time.
Yeah.
Thank you for joining us.
Good, thank you.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.